Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of Emirates Diabetes Endocrine Society, I would like to warmly welcome all of you who's with us here on site in person and those who are online for the new version of the UAE Endo Club, now operating under the umbrella of Emirates Diabetes Endocrine Society. Every successful project is built up on a strong foundation and solid pillars, and our Endo Club is no exceptions. We are proud to have great founders from our endocrine and diabetes community, whose vision had led to the groundwork of what we see today. We sincerely thank them for their vision and dedication, and we are committed to continue and building up what was established in the past. A very special thank to my friend and long-term colleague, Dr. Ahmed Hassoun, whose enthusiasm and commitment over many, many years have been instrumental in sustaining and advancing this initiative. And I'm sure under this new chapter, we will also achieve more. Dr. Hassoun, thank you very much, and over to you.
Thank you, Dr. Fathiya, and thank you everybody for being here. And thanks for the people online also. This is the first time we're doing it together under the umbrella, and it's the first time, but not the last time. It's the first time, and we're going to continue working together. I think just a few words about the history. I think we can talk more in the future, but for the time being, the club started around 2002, actually. So many years already passed. And some of us getting older with the white hair. Maybe in the future, we're trying to put the pictures of the people when they were younger, when they started, and what is it currently now. But it was really a good idea when Dr. Fathiya approached us and talked about working together. And I think this is a very good for all the society as well as to us. And I think that will booster the activity. It has been doing very well, with the exception during the time of COVID, when you have some a little bit online and virtual meetings, but again resumed. And now I think from now on, we're going to have a better even meetings in the future, and looking forward for all of you being attending there. And I think we have a lot of work, me and Dr. Fathiya and MCI, to do a lot of work on establishing things and helping you to get involved and attend this meeting. You know me and you know Dr. Fathiya. Just what we're going to talk about the agenda. I think we started already by the welcoming remark, and I'd like to move on to, this is the agenda basically. Dr. Aftab Munir, who is well known to many of us here, he is going to start, and basically he will talk about hit early, hit hard, elevating cardiovascular and kidney protection for type 2 diabetes patients with Fineron. And I would like also to thank, Bayer for making this possible and sponsoring this meeting. This will be followed by Dr. Bashar Effendi, who is going to be online. He's going to talk about something very important for the coming Ramadan, the 2026 update on diabetes and Ramadan risk calculator. And last but not least, Dr. Maher Jallo, who has a very nice case to present, interesting and more interactive. It's not just polyuria. It's stepwise diagnostic journey, and then we'll leave the questions also at the end, and maybe we have some question in the middle of this. With that, I would like to present my colleague, Dr. Aftab Ahmed. Dr. Aftab Ahmed is a consultant in diabetes endocrinology at the Imperial College London in Abu Dhabi, and clinical professor at Khalifa Medical University. Plenty of years, more than 20 years of clinical and academic and leadership experience in the UK, as well as in the UAE, including serving as clinical director at the Royal Liverpool University Hospital. A former sub-dean and honorary senior lecturer at the University of Liverpool, contributing extensively to the medical education and curriculum development. Led National Diabetes Initiative as Strategic Clinical Network Lead for NHS England, and Aqua, I think it's Aqua, Diabetes Lead for Northwest UK. Very much welcome, Dr. Aftab. Good to hear you and to be here with us. Thank you.
Good evening, everyone. Thank you very much, Ahmed. That was a very kind introduction. And definitely thanks to EDES for inviting me to do this, and Bayer for sponsoring this. I am going to talk about diabetes hit hard and hit early. I've got a lot to cover, so I'm going to sort of crack on. We already know we have got 4 pillars suggested by almost all guidelines now, but ADA is taking the lead. I'm just going to talk about 2 of them, the glycemic control and the agents with cardiovascular and renal protection. That's the key thing. But while talking about the glycemic control, there has been a paradigm shift, and I think it's time to redefine what is uncontrolled diabetes. And I'm going to do a proposal today for everybody to chip in at that. I'm sure the question times. How do we currently define uncontrolled diabetes? Now, for decades, it has been glucocentric. HbA1c has been our marker for whether we document controlled or uncontrolled. It depends on whatever target we have fixed for our patient, and then we will document it. So in other words, we are primarily glucocentric. But this changed. Many studies over the years, but 3 key areas. One was reports of the high prevalence of early kidney disease in newly diagnosed, and similarly heart failure found in newly diagnosed. And then I think the meta-analysis done after decades of focusing on glycemic control, when we look back to see the impact of tight glycemic control on cardiovascular mortality and renal protection, was quite disappointing actually in terms of those major areas. I think these slides, yeah. So essentially, one of the studies that pointed, or many studies, but one of the big studies, US veterans, when they looked at newly diagnosed diabetes, they found 31% already had DKD. 31% at diagnosis. They already had it. So it's not about HbA1c, it was at diagnosis. And the Arab world data, reported 45% in newly diagnosed. So which means our patients are already affected quite significantly. Now we can talk about delayed diagnosis and so forth, but in this day and age, we don't really delay that much. Our diagnostic capabilities have increased and the facilities are available. So this is a pretty high number in terms of newly diagnosed. And then more importantly, the prevalence of heart failure in newly diagnosed type 2 diabetes patients, echographic evidence, 41% had early LVDD at diagnosis. And I think the Department of Health, at least in Dubai, is taking note of that, and screening for heart failure is going to be introduced this year at diagnosis. And this is the important thing, that in the so-called well-controlled type 2 diabetes that we have, which means they have achieved their HbA1c target, there was no evidence of diabetes complication, they didn't have hypertension, they didn't have coronary heart disease. In other words, they were very fit, so-called well-controlled type 2 diabetes patients. 60% of them had echocardiac evidence of early diastolic failure. 60% in the so-called well. And then if we look at the impact of tight glycemic control and HbA1c, the meta-analysis done, I don't know if you can see the study, these are all the big studies done over the decades. And when they looked at the impact on all-cause mortality and cardiovascular events, they really found no difference between intensive treatment and non-intensive or standard treatment at the time. So another group thought, okay, maybe the American and the rest of the world was different, because that can't be true. For decades, HbA1c has been our gold standard. Surely that can't be true. We are working so hard over 20, 30 years. So there must be a geographical variation. But unfortunately, the left Americans and the right, the European and the non-American, the rest of the world studies, when they compared them, there was no difference. So there wasn't a geographical variation. HbA1c was not at the center of everything. It's not like we're going to demean this. HbA1c remains a gold standard marker. Microvascular complications are there. And the UKPDS data said otherwise, although that's a standalone at the minute, because the rest of the study is a meta-analysis of all of them, unfortunately hasn't shown that. Well, all of this put together did bring a paradigm shift. We know that. Because if we look at the 2019 ADA guidelines, this is the interesting change, shift right in front of our eyes. First line metformin And if you look at it, it is then HbA1c based. 2019, up till 2019, our next step was based on HbA1c. In other words, you put them on metformin, their HbA1c within target, you don't have to worry. But if their HbA1c is above target, then we started looking at whether they had established cardiovascular disease and so forth. And then we moved forward. Literally 2021, 22, it started to change. But 2024 is very clear. After the lifestyle, there was no mention of HbA1c in the guidelines. They don't refer to HbA1c. It's about cardiovascular risk reduction now. The primary aim is cardiovascular risk reduction. But what really got my attention in this guideline is that they had put indicators of high cardiovascular risk. In other words, high cardiovascular risk type 2 diabetes patients parallel to established cardiovascular disease, heart failure, and CKD. So in other words, if we see a high risk type 2, we have to treat them as we are treating an established cardiovascular disease. And I think that was a major shift, that they are the same. We don't have to wait for them to have developed an event to take them seriously. We have to take them seriously on day one, the day we realize their high cardiovascular risk. And 2025 guidelines depicts it quite nicely. What they have done is they have prioritized it now. So they have literally made it step one, reduce the cardiovascular risk. No mention of HbA1c. If you see patients with high risk, you would actually treat them. The second is weight, and third priority is target HbA1c. We don't take it that way. We're dealing with them in parallel in reality, because when we treat one, we treat the other. But the emphasis is shifted to cardiovascular risk reduction. And how is that? Because the initial management has changed. The first two medications or three medications that we have to choose in our type 2 high-risk patients is no longer glucocentric. We don't base it on HbA1c. We shouldn't base it on HbA1c based on the evidence that is in front of us. Habit is one thing. Evidence and guideline is something else. So if you look at it again, you can see the indicators of high cardiovascular risk, which we already know. Starting from if the patient has got hyperlipidemia, they're hypertensive, they're overweight, obese, microalbuminuric, smoker, any one of those makes them a high cardiovascular risk patient. And if that is the case, the first step is put them on SGLT2. There's no mention of anything else. There's still no mention of HbA1c. If you find any of these risk factors, we have to put them on SGLT2 and GLP-1. Now they have put or there. 2024 did not have or. It was and or. And interestingly, if you read the 2025 text, they have actually kept it as and or. So why in the flowchart it doesn't show, it surprised me. But it is and or, which means if they're high cardiovascular risk patients, they're overweight and obese, depending on what percentage we are dealing with in terms of our population, they should be on both for cardiovascular protection. That's the evidence. And this is the consensus statement, that patients who have got high cardiovascular risk, established cardiovascular disease, CKD, heart failure, we already know. But if they have got cardiovascular risk factors, they're not established cardiovascular disease, they have to be treated the same and they have to be put on SGLT2 and or GLP-1. And this is the key sentence, irrespective of HbA1c. HbA1c does not play a role in your decision making anymore. And it is independent of whatever other medications they could be on. As a habit, we know that 80% of our patients are probably on DPP-4. It doesn't matter. You have to add SGLT2 irrespective of their HbA1c. That's the consensus statement based on the evidence that I've just shown you. And I'm going to address the and or. Hani, Sabur, and myself were in the clinic, and we suddenly, I called him about this patient of mine. I said, why is this not on Ozempic? And he said, turned around and said, boss, I don't know why is he not on Ozempic? Why are we not using both together? I said, I haven't seen the data yet. Is there any data? And we looked, nobody had done it. So we did a meta-analysis of around 1 million people. And we found that compared to single therapy, if they're on GLP-1 alone or SGLT2 alone, the combination therapy significantly reduced all-cause mortality. So the combination therapy actually was saving lives compared to monotherapy with either of them. So the OR concept, we started questioning. This is 2024. And we did do a call out in the paper that we should start looking at this quite seriously. Interestingly, the very next month, another group published a beautiful study. And they took all the big trials, took the high cardiovascular risk patients out, and looked at the combination therapy. So whether the patient was on GLP-1 alone and added SGLT2 or vice versa, there was a 30% reduction in MACE in both groups. Doesn't matter which one they were on first. They could have been on GLP-1, SGLT2 added, or they could be SGLT2, GLP-1 added. Either way, the combination therapy reduced MACE by 30%. So 2 studies came out, one after the other, which was going to have an impact. But this is one of the best data I have seen, the Danish registry. They look back 20 years, around 60, 70,000 patients. And they had all the combinations in their register. And they looked back and followed them up and look at the mortality. And look at this. Patients on metformin and sulfonylurea, their mortality stays very high. In other words, improving their HbA1c was not making any difference whatsoever. Well, very little difference. They are at the height of mortality. So achieving HbA1c wasn't doing it. But look what this combination was doing. The metformin, GLP-1, SGLT2 combination, the lowest mortality in this triple therapy group. And the rest in between, which means reducing HbA1c wasn't it. These drugs were doing something different. So ADA standards 2024, they changed then. And they have added combined therapy SGLT2 with GLP-1. They use the word may be considered. And they still do and or. ESC, on the other hand, I don't know if you came across this, they did a corrective paper. They changed the language. The language was and or, and after that, they basically they said and SGLT2. It is not a choice anymore. It is pretty much guidance and evidence-based now that the combination therapy of SGLT2, GLP-1, and based on the Danish data, I would propose metformin, the UKPDS data comes into play there. The triple therapy is saving lives, and that is independent of HbA1c. I keep on repeating that. We really need to change the way we do, and I'm proposing this now. And it is, I think, up to us to discuss and decide and debate. But I am proposing that we should reconsider what we call uncontrolled diabetes. Uncontrolled diabetes should be at least documented if they're not on SGLT2, even if their HbA1c is well controlled. Because unless we do that, we will not change the minds of the insurance companies. And the reason I know that is because I was given the opportunity to sit with the 7 CEOs of the 7 major insurance companies. And I presented this data and they just didn't believe it. They said, we don't know anything about this. Their view was that DKD heart failure is 5% and less. And when I suggested this to them, I said, you really have to consider this. They said, well, we can't because the guidelines don't say so. I said, what guidelines don't say so? They said, if the guidelines tell us that HbA1c, we will have to do something about it, although it's still, a big ask for them. So what they're saying is that doctors need to document. Why are they not documented uncontrolled if you're saying this is such a big role? So I'm proposing that at least we should consider documenting uncontrolled diabetes because they're not on the cardiorenal protective medication that they should be on to save lives. That's my proposal. And I think the question we need to ask for UAE in particular, that's where we're raising the question, what percentage of our patients are high cardiovascular risk? PACME has answered that. I found a study because I was thinking about this 4 years ago and I desperately looked for it and I found a study that said 96%. And lo and behold, PACME came out. Somebody else was thinking the same, which I was very happy about. 99% right across the Middle East are considered high cardiovascular risk. Actually, the word used is more than 99%, and I think that means 100%, which means every single person that walks into our clinic is high cardiovascular risk. We cannot ignore it. We cannot move away from it. We cannot just be HbA1c based anymore. when all our patients are high cardiovascular risk? We have to close our eyes just like we used to do with metformin, start metformin, then think HbA1c. We need to put them on these medications, then think. I know there are insurance limitations, but the insurance CEOs have said if it's documented, the guidelines, the national guidelines say that, we have no choice, but we'll have to follow it or make way for it. It's not just PACMIA. The score 2, when I was looking at it, I don't know if you've tried to do score 2, you have, when you're calculating, you have to put the region in there. And if you put the region in there, UE comes under high cardiovascular risk. I looked at their heat map and look at that. That's practically orange and red. So they're saying what PACME are saying. All our patients are very high or at least high cardiovascular risk patients. Let's take them seriously. And that's the key message. All our patients are very high cardiovascular risk. And I think all of them should be put on at least SGLT2 on day one. On day one, wherever you see them, whoever is seeing them, doesn't matter what they're on, they should be put on SGLT2. That's my view, my proposal. We can talk about it, but the sad reality is the PACMIA, which obviously is from the elite groups, not the general practices, 37% are on it. The global data is about 10%. The global data is even worse. In established cardiovascular disease, it's less than 3% on it globally. That's how behind we are of the guidelines. And the guidelines have been out for 6 years now. GLP-1 is even worse. And this is PACMIA here in our doorstep. I know insurance limitations are there, but that's why I'm proposing that we at least start documenting that this patient. I'm doing it, and I can promise you, every time I do it, the insurance approves it. This is honest to God truth. They reject it. I reiterate the sentence, high cardiovascular risk should not be, and 5 minutes later I get a pharmacy saying approved. Because they demand that we document it. And that brings me to the cardiovascular impact from the kidney disease. And this is the data. And these are big numbers from which we get 40% of patients already have microalbuminuria. I think everybody knows, I don't have to reiterate. You get microalbuminuria, you're already a very high cardiovascular risk patient. So what are we doing about them? Only 49% of patients are being screened. Half the population is not even being screened, and the rest, when they're screened, only 3.6% are on the recommended treatment now. 3.6. I mean, inertia has to have a limit. This is beyond inertia. We need to start figuring out why, especially in our own geographical area. When half our population has got microalbuminuria, pretty much, every second patient walking in, we need to be looking at. But do we? And we know the cardiovascular risk is 4 times higher with proteinuria. Initially, they are already on the way to having a heart attack, stroke, and mortality. We already know giving them any of the SGLT2s, we leave a residual risk behind. A significant residual risk. So SGLT2, the reason I gave the SGLT2 scenario, because there's a lot of debate about, should finerenone be used? From my point of view, any diabetes patients in UAE, in Middle East, should have been on SGLT2 on day one, period. Day one of seeing any doctor, period. Which means this debate shouldn't even arise. Should we start together with benefit? They should be on SGLT2, period, because there is, despite that, there is residual risk. SGLT2 improves it, there's residual risk. Now we know GLP-1 has reduced the risk significantly. The flow study showed that, but they leave a residual risk behind. And when we combine them in this study, no treatment compared to GLP-1 SGLT2, significant improvement, much, much better than not treatment, but look at the residual effect still left behind. Which means even if we take these steps, which we are only 13% or 12% of our patients are getting, 90% not even getting the first steps, even if we got to this stage where we give them everything, the residual effect is there, a significant amount. And why is that? Because we already know that RASI only impacts one of the pathophysiologies of CKD. SGLT2s, another. But that leaves us with inflammation and fibrosis. That was not being addressed. And this is where finerenone came in. A non-steroidal, much more selective. That was the idea, isn't it? Because we had issues with spironolactone, the diabetes part of it, eplerenone was very good, but hyperkalemia was still an issue, and finerenone actually found the middle ground. So this is where Like we're doing with everything, hyperlipidemia, we're doing dual therapy, hypertension, dual therapy, because diabetes, the octet ominous, the whole idea is that we address as many of the pathophysiologies to actually give you the perfect control, or as good a control as we can give you. And this was followed by all guidelines, really. From ACE to KDIGO, the ADA, ESH, everybody said the same thing. That if you have got microalbuminuria, and you know the definition of microalbuminuria, and you get 2 of those readings, consecutive readings, or any readings within a year, as far as I'm concerned, they should be on finerenone in addition to your other 3 medication, which is the SGLT2, GLP-1, and RASI if they are hypertensive. Even if they're not hypertensive, and that's being debated. And why is that? Because finerenone, when given together with SGLT2, had an additive effect. It reduced the ACR much more than given alone, either of them. Smaller numbers, these are not huge numbers, but numbers nonetheless. And the pathophysiology makes sense. And the proportion of patients in the combination therapy, there was a much greater reduction. A higher number of patients were achieving the target. And this is the best bit. The combination therapy, the risk of hyperkalemia that we are so afraid of, was minimal, was reduced almost as placebo. So if these drugs are together, and again, the question doesn't arise. I remember, a lot of this debate when finerenone came out, SGLT2, should we give together? That, for me, that never was a question, because every single one of my patients is on SGLT2. The 20% that are not on it are the ones who are intolerant, had side effects, or refused to take it. And that's worldwide data. 80% should be on it. So I've never had this issue. And this issue should never arise if we actually redefine and control diabetes. And this will never happen. And if you take simultaneously the significant reduction in UACR, you can see that. The combination therapy right across the board. Again, this has been shown, finerenone reduces cardiovascular mortality, MACE, 13% reduction. I don't have to tell these things. These are already well known. Everybody has said it. That's why I'm not spending too much time on it. I want to go into the practicalities, and this is the practicality. We can't achieve any of that if we don't even screen our patients. It has to be a system responsibility, an institutional responsibility. It has to be a governmental responsibility. Insurance probably has to be brought in. A platform has to be given where this has to be a mandatory thing. We really have to screen every single patient. We know microalbuminuria is an individual cardiovascular risk. How is it that we are not screening our population? If we don't screen and we don't define them, our doctors don't realize what albuminuria cutoffs are. You'll be surprised when they do surveys, and that's a big gap. So I'm not surprised at the inertia. Inertia is there because institutions have lagged behind. And this is the data. This is the screening globally. We're talking what? 57, 29, 60%. More than half our population is not even screened. If you don't screen them, you're not going to treat them. So we are failing. Now, Imperial, we are proud of at least one thing. 100% of our patients are screened. 100% patients are screened. We have had this data repeatedly. But this is the sad reality. Look at the sad reality of Imperial as well. We claim to be brilliant at what we do. 100%, look at the RASI. We're still 62% on RASI. We should have at least 90% on RASI. That's not a good reflection on us. We had to publish it because it has to be published. But look at finerenone. This is 3 years down the line. 40% are, it's us. I'm part of this. I'm not sort of putting it all, look how wonderful I am, I'm presenting it. I am saying we are all part of this. Our mentality hasn't really changed from HbA1c. That is all we talk about, think about, and focus on. And we forget the practicalities. I think that's where redefining things are needed. This is Imperial. And I was trying to think, what are the causes? I looked at the data, I looked at the colleagues. There is a lack of awareness of the early use of the combination. Everywhere I hear this debate about finerenone, SGLT2, and so on and so forth. That's still going on. As far as I'm concerned, there is no debate. But the worst bit was hyperkalemia. That was magnified to a limit that is beyond me. I was asked to chair a meeting for the Saudi nephrologists, because apparently in Saudi Arabia, nephrologists have taken charge of this. They think nobody else is allowed to do finerenone or SGLT2, the endocrinologist. They don't like the primary care. So I was chairing it, and there were about 400 doctors from Saudi. And when I said, I'm sorry, but this is a primary care drug, they were all up in roar. 6 hours later, they all left convinced when I showed the data and we talked it out. And they said, we will go and share it. But this is the issue, because they were highlighting the risk of hyperkalemia, and we had to show them the data. I said, what risk of hyperkalemia? There are 4% patients. There's non-fatal, 0 fatal episodes. 12% or so are between 5.5 and 6, which is not even clinical hyperkalemia. It's a biochemical hyperkalemia. It doesn't even have an impact. Yes, you monitor them, but for God's sake, don't limit the prescription. It's just like any other drug with side effects. But that was supposedly the biggest fear. And we know the difference between placebo is 0.2 millimoles in potassium. It's not even significant. And this is what was horrifying for me, that I found out in Dubai. I won't reveal my sources. But in Dubai, the endocrinologists, I was told, are referring to nephrology for finerenone prescription. I don't want to believe that. I refuse to believe that. But I was told that's absolutely true. And then when I checked with a few endocrinology colleagues, and I don't know which hospitals, I won't again give the name, they said, yeah, because it's it's a serious drug. And I said, what is your referral criteria? And they're referring to nephrology with EGFRs of 60 and 70 with microalbuminuria. I said, what endocrinologist does that? What family doctor does that? What GP does that? Why would you refer it? I said, what are the criteria? What are the referral criteria? The referral criteria in nephrology is less than 30, not 60, not 45. I don't know why we have brought 45 into this play. Are we saying that our doctors are incapable? Why wouldn't we train them if that's the case? There are not enough nephrologists in any country who can take the load of these numbers. They just cannot. It's not possible. There are more GPs, family doctors, internal medicine than endocrinologists, and more endocrinologists, nephrologists. So they can't take the burden. And these are the referral criteria. Why would they be prescribing finerenone or SGLT2? SGLT2 is the first line drug for any diabetes doctor. And finerenone is the first line drug the moment you find ACR, and the ACR is high when the EGFR could be 80 and 90. That's the first sign of renal disease. So I really can't understand, if that is happening, that shouldn't happen. So I'll conclude. My first message is, any doctor who reviews a type 2 diabetes patient in this country, I will talk alone, okay? When you see them for the first time, doesn't matter if they're newly diagnosed, 10 years, if they're not on SGLT2, please ensure you put them on SGLT2, irrespective of what they're on, what their HbA1c is. Don't think. It's like metformin. My advice is, for further cardiorenal protection, put them on GLP-1. And if they're not affording insurances, please document uncontrolled diabetes, because they really should be. And these are for overweight and obese. You know the percentage of overweight and obese in UAE? It's 88 to 90%. 50% are obese and the rest are overweight and obese. 90%, that's practically all your patients. So I can't imagine why any doctor will not just document it. I'm not saying, I know the limitations. Just document, listen, this guy should have been on it. They're not on it. They should be on RASI, but screen for ACR. Make your institution do it. Put it in writing. Make a fuss about it that I need to screen this. And I think EDES will take a lead in insurance companies, the DOH, DHA. They have to combine on this. It has to be a mandatory thing. Imperial, we have done it. I'm sure it can be done everywhere else. And this is the key message. These are frontline drugs. SGLT2, GLP-1, SGLT2 are frontline drugs. They are for doctors in primary care, in SEHA, internal medicine. All of you are the ones who should be starting this. And if they're not on it, I shouldn't use the word crying, but I think it's serious. And I think if a nephrologist, this is my view, or a cardiologist has to start any of these medication, we have really failed our patients. So please take the lead. Thank you very much.
So thank you very much. It was very enlightening and very exciting and encouraging people to do that. And I think some questions will be at the end. So now we're going to move to our second speaker, who is also well known to all of you. He is going to be online, live online, and he's Professor Bashar Effendi. Bashar Effendi need no, again, introduction, just a few words about him. Senior consultant endocrinologist at Tawam Hospital and clinical professor, Faculty of Medicine and Health Services, the United Arab Emirates University, founding member of the UAE Endocrine Club. He's one of our founders. And a treasurer, a Gulf Association of Endocrinology and Diabetes. Today, he is going to talk about an important topic, which is Ramadan is coming. Mabruk alaikum Ramadan in advance. And the topic is the 2026 update on diabetes and Ramadan risk calculator. Bashar, are you with us?
Yes. Assalamu alaikum.
Wa alaikum assalam. All yours now.
Good, good. It's my pleasure to be a part of this meeting. Very happy to resume the activity again. Let me just share this, especially that this is now in collaboration with the EDES and the leadership of Dr. Fathia. Do you see my slides, Ahmed?
Yeah.
Dr. Ahmed, can you see my slides?
Yes, I can see it, and I think maybe you can magnify it, put it as slide presentation.
It is magnified now.
Isn't it? No, it's not. You need to put it on. Yeah, now it's better. Good. Thank you.
Okay. All right. So it's my pleasure. Thank you, Dr. Ahmed. And I will be talking about the updated diabetes and Ramadan risk calculator, then new modifications on that. I will be covering the importance of fasting risk calculation. Again, I will address the new modifications on the new calculator. I will discuss a little about the new studies, validation studies, and then I have two simple cases just to wrap up. Now, as you know, risk stratification is really very important since patients behave differently during Ramadan fasting. And also there is a wide variability in the physician evaluations and recommendations for different patients. So it's not strange for all of us, we know that same patients go to different physicians and they get different evaluations. Some of them will tell them you're low risk, high risk, moderate risk. So it is confusing to patients as well as physicians. It really puts a lot of pressure on physicians, practicing physicians, and in the same clinic, I mean, might be really stressful to all the staff there. Now, again, stratification is really important to help the patient safe fasting, and very important about the risk calculator that it actually aligns the medical safety with also religious recommendations and rulings. Now, as you know, over the past 20 years, we have moved from expert opinion. So it was whatever you want, whatever you feel, you could do it. Then we moved to the four-tier system, very high, moderate, and low. Then we moved to the traffic light three-tier system, high and moderate and low. And now, since 2021, we moved to risk scoring and calculation. Now, I would not go about the previous risk calculator. I will go straight away to the 2026, and I will say a few things about the previous one. Now, in the new one, in the 2026 risk scoring, you could see pregnancy as number one, and you could see that it scores 6.5. And I will show you later that any score more than 6 is considered as high risk, and these patients would be advised not to fast. So pregnancy, any type of hyperglycemia, GDM, type 1 or type 2, a high score, and patients should be advised not to fast. In the new risk calculator, we grouped, and all of these are based on new evidence and new studies many of you in the audience were a part of. So type 1 and LADA were grouped together. It gives 1 point to the patient. Type 2 diabetes or any other type of diabetes gets 0 points. Moving to the duration of diabetes, we used to have less than 10 and more than 10. We have now new evidence that more than 20 years of diabetes is actually riskier than having less than 10 or 10 to 20. So that's why the scoring now 0.5 and 1. Then we move on to the medications, and you could see here any possible scenario for treatment for any patient. From pre-mixed insulin to insulin pumps to oral hypoglycemic agents or so on. But you could see here that you could put anything you want and you could add them up. So a patient might get 2 scores here. If a patient is on a basal insulin, for example, plus any oral hypoglycemic agent. Even for those who are on medications that do not include sulfonylurea or insulin. Now, based on 2 studies actually, there is a mild risk with these patients, and they get 0.25. Now, for hypoglycemia, item number 5, now you have all types of possible hypoglycemia. We have the severity, we have the timing of the hypoglycemia, very important. And again, as you can imagine, that hypoglycemic unawareness is the worst one. And for patients with hypoglycemic unawareness, the risk is very high, and these patients would be advised not to fast automatically. So you don't need probably to calculate the risk. Whenever it's clear, severe hypoglycemia, and episode of hospital admission, a score of 5, probably plus insulin, that will take the patient straight away to high risk. So common sense actually, but the calculator is there to help you score your patient. Next is the level of A1C. Again, we have good evidence now that less than 7.5, 7.5 to 9, and more than 9 are good. So now we have an evidence for that. It was a clinical decision or expert opinion, but now we actually have the evidence for that. Moving to glucose monitoring, if there is no glucose monitoring at all, then the patient will get 2 points. But very important, and this was added recently, and as you all know, that CGM is very helpful in reducing the risk of hypoglycemia and hyperglycemia, and helps patients to break their fast whenever they have any of those. So for that reason, CGM, again, based on new evidence, CGM patients will get minus points. So this is a protective factor, and the patient score will be reduced, which is really good. They might move from moderate to low risk. Now, hyperglycemia, emergencies is still the same. If anything, within the last month or 2 to 3 months or more than 6 months, you get 0, 1, or 3.5. Macrovascular complications, we have new evidence now for that. Patients with stable macrovascular disease get 2 points, but if the macrovascular disease is not stable, and we need a lot of work here to define unstable, congestive heart failure, angina, whatever, and we need our cardiology colleagues to help us on this aspect. But we see that nephrology moved a lot in this regard, and we have what we call the RAC initiative in evaluating patients who do not have diabetes but have nephropathy. And as you see here in the nephropathy, the microvascular, we have item A and B. If the eGFR is less than 30, the score will be 6.5, and that will go less if the eGFR 30 to 45, and so on. The new item that was added is in neuropathy. So clearly, evidence there now from few studies from the global survey that 1 microvascular complication puts the patients at some risk. However, 2 microvascular complications will put them on a higher risk of hypo and hyper and breaking the fast. and 3 microvascular complications are even worse. So that's why each microvascular complication was given 1 point, additive points, so you could put 1 or 2 or 3 here. Now, cognitive function, we are clear about this. Now, again, there is an evidence for that. Patients who are frail or have impaired cognitive function are considered high risk, as you might imagine. So a patient that is really frail should be advised, he and his family, that he should not fast. Physical labor is still the same, no change in that regard. Fasting education is very important and was added. So if the patient receives diabetes, Ramadan-related education, then will get 0. If no education at all in that regards, then the patient will get a point for that. Fasting hours, 16 hours more or less, that's still the same, 1 point for more than 16 hours. Now, when you sum up these scores, then you will get to the final score. If the score is between 3 and 6, this patient is at low risk, and fasting is probably safe, and patients should fast. You could see here also the religious recommendations. And these were approved by the authorities. Religious authority from Al-Azhar in Egypt. Now, if the score is between 3.25 and 6, then the score, the level is moderate, and the medical recommendations that fasting safety is probably or uncertain, so it's not safe as in the green, or not unsafe, it is uncertain. And in that regard, then patient fasting will rely on many factors. You need to evaluate your patients and see their past experiences. Then you need to modify their treatment. As for any other patient who wants to fast, you need to modify the treatment and you need to monitor. Now, if the score is more than 6 points, then fasting probably is not safe, and these patients should be advised against fasting, and religious authorities will also give the same recommendations. Now, this is the prevalence for the updated risk calculator. You could review that reference if you like. Not only that, in our guidelines and in our common guidelines for the 2026 that is not published yet, but the ADA standards of care now clearly have the same risk calculator. You could see that in chapter 5, and we're very proud to have this there. You can see it's the same one. Now, validation studies for the 2021 risk calculator, there are so many of them, probably 18 by now. One meta-analysis, Dr. Fathiya was a part of many of those studies. We have more than 10,000 patients in these validation studies. And if you want to summarize the findings, it looks like the diabetes risk calculator very helpful in predicting hypoglycemia and hyperglycemia. And some said that it overclassifies a few aspects, and that's where the modification came about. Now you can see here, these are many of the validation studies, international ones. You could see from different countries, and each one of them came up with a conclusion. And again, taking into account all of these studies, the risk calculator was modified, and these were adopted. There are so many emergent evidence. We have so many studies coming now on some groups that were not studied earlier. You could see here, for example, type 1 CKD, type 2 proteinuria, insulin regimen. We have macro and microvascular patients. We have retinopathy patients. Many of the subpopulations that were not studied at all in the past, we addressed in the studies of the global surveys. And again, many of you guys, thank you very much, are involved in many of these studies. The common issue of the Journal of Diabetes and Endocrine Practice is is about Ramadan. I like to thank Dr. Salim for supporting us. So soon you will have this publication with, I think, about 20 papers on Ramadan fasting. Now, for us, now we could have it in many ways. You could have a hard copy, but for us in Tawam Hospital, in Al Ain Saha, we already adopted this in our Cerner system. You could very easily access this tool, and you could go through 3 steps to move and get to the risk calculation. And when you get to the risk calculator, and this is the old one, we are working now on modifying this. You just tick 1 tick for each one, and then it takes not more than 1 minute, and then you get the final score, and here the risk level, and on the right side you get the recommendation. You could also access this using the DAR Academy, and you find this under risk calculator. Again, you might have a hard copy, and you could just tick it, and it takes you a few seconds. Now, I will show you how to use the risk calculator for one case. But before that, let me remind you that evaluating patients before, during, and after Ramadan is very important. It's a process. It's not only 2 days before Ramadan. It's a long process. And this is a very important chart. I would not go through this, but remember that you need to evaluate the level of risk for your patient. Then you need to discuss with the patient and the family about the decision to fast or not to fast, and to try fasting. If they are going to fast, a trial fast is good. Then you need to reevaluate just before Ramadan and see how to modify the treatment. But very important also is to follow the patients after Ramadan in order to address their modifiable risk factor. And you could see now from the simple case I'm presenting that if you address their modifiable risk factor, you might reduce the risk level in the future. Now, this is a simple case of a patient, 47-year-old man, type 2 diabetes for 11 years, hypertension, hyperlipidemia, symptomatic hyperglycemia, not compliant with his medications, unemployed, sedentary lifestyle, again, hyperglycemic, not well controlled, fasting duration, 14 hours. Remember, when you are reviewing the case, to remember the risk calculator. And when you get used to that, it will be very easy to decide the level of risk, even sometimes without even opening the system, the Cerner for that. Now, patient here had no hospital admission for any related issues, fasted past Ramadan, and this patient also sometimes fasts on Mondays and Thursdays, and he had diabetes education in the past related to Ramadan. His medication are clear here: sulfonylurea and D4 inhibitor, metformin, blood pressure 138. Patient has diabetic retinopathy. Again, this is very important in the evaluation. Full pulses. A1C, very important, 9.2. And now just take a second and think for yourself. What would you think this patient? Is this patient a low risk, moderate, or high risk? Just take a second. And I know if we have a pool for that, I know some of you will say low, some will say moderate, and some would say high, and that happens actually in real life. And this patient might go to 3 of us, and it will be confusing to him after the full round, and sometimes might go to other subspecialties and give them different recommendations. Now just go over the calculator, very simple, and you put the points where the patients, where it applies for the patient. Half a point here for more than 10 years, less than 20. Half a point here for Amaryl and sulfonylurea. Nothing, no hypoglycemia, nothing is related here. A1C more than 9. Then SMBG done suboptimally. Then 1 point here. No other history, macrovascular complications, no hypoglycemic, hyperglycemic admissions to the hospital. GFR is normal. Okay, we have here a 1.4 microvascular complication, the retinopathy. 0, 0, 0 for the list, and you will add them up and you get a 4-point. So this patient has a moderate risk, and again, you need to review with the patient past experiences, very important in this regard, and you need to modify their treatment. You need to always monitor them, maybe having an access to them, to your service through nursing or educators will definitely help to reach you in case the patient developed any abnormalities. Then you might need to bring them in or modify their treatment over the phone. And I'm talking about other patients that are on insulin or other medications. A trial fast is very important. That should be done a few weeks before Ramadan. Then you need to discuss the potential risk with the patient. You need to discuss medication. That's where education comes very, very helpful. Refer them to education and probably also to an expert nutritionist. You need to discuss the timing of physical activity and Taraweeh prayers, very important for many of these patients. As you know, exercise maybe should be done in the 18 hours, not the fasting hours. But again, that is related to the type of medications and control for a specific patient. So everyone is different. Now, very important to emphasize the need for self-monitoring of blood glucose. And you need also to discuss the timing, and that is also related to patients' medications. Very important is to check before sunset meal. That's the timing that hypoglycemia might happen, but also after meals is very important. Very important when you're evaluating your patients and making a deal with them that, okay, you will fast, you're low risk, moderate risk, or those who insist on fasting. Very important to review breaking the fast rules. Very important when the sugar is very high or very low, when they have symptoms of hypo or hyperglycemia, and if they're acutely sick, fever, diarrhea, whatever, then they need to break their fast. And that's very important. If you help them, and you let them know that the rules, it will really make a big difference for them. Now, treatment modification for this patient, I think is not, it's easy for the audience. In the case of metformin, probably you do not need to modify metformin, but if the patient has, very tight control, you might consider the highest dose at iftar and half of that at suhoor time, and on many occasions you do not need to change. If it is an XR medication, probably you do not need to change anything unless there is a tight control. You might consider cutting a quarter of that and give at iftar time. Now, regarding sulfonylurea, again, it's the same. If it is a once daily, you give it at iftar time, but you might consider cutting the dose if the patient has tight control. And very important to check the sugar before iftar time to make sure there is no hypoglycemia. And in that case, you might consider cutting the dose. If the patient is poorly controlled, you need to monitor more, because we clearly showed a higher A1C before Ramadan. Higher A1C will cause more hyperglycemia, but also more hypoglycemia. So do not think that if the A1C is high, then they have no risk of hypoglycemia. Yes, they do have increased risk of hypoglycemia if the A1C is more than 9, for example. Now, for this patient, reduce Amaryl and the other medications, probably you do not need to modify. A simple case. Now, again, close monitoring and maybe a hotline access or whatever, very important. But you might need to further reduce or modify the treatment. Very important aspect of the risk calculator is to work on modifying the modifiable risk factors. And I'm talking here in this case, if you change medication, if you limit hypoglycemia in other cases, if you do SMBG more frequent, if you refer to education, if you control the A1C ahead, if you change the type of insulin, for example, Yeah, if you use CGM, then definitely the risk will be reduced from sometimes high to moderate and from moderate to low. And you're talking about a few points here and there. Insulin, I mean, if you go from basal bolus or pre-mixed insulin to other medications, you might reduce the risk by more than 1 point. A second case, very simple and fast case. Now, this is a 26-year-old lady, 37-week pregnant, 37-week pregnant, and she is on Detamir and Humalo, well controlled, and she has absolutely no other issues. Her A1C is 5.8 and GFR is 124. Now, this case is a very simple case. Young patient, well controlled, motivated, no hypoglycemia, well controlled, and she has relatively short fasting duration. What do you think her risk category is, and what are your recommendations? Just take a second for that. And as I mentioned, any hyperglycemia in pregnancy, regardless of the control, is considered as a high risk. And again, regardless of the type of diabetes. And a high risk for the mother and for the fetus. And there are unpredictable glucose swings, and not only GDM, also GDM on diet. I mean, we reported that patients GDM on diet have an increased risk of hypoglycemia, and also the SMBG is not reliable since patients do not check their blood glucose before iftar. They do so after iftar, and we have increased reports of hyperglycemia. But when you use the CGM, you figure out that also they have unreported hypoglycemia and ignored. Now, the risk in pregnancy is not only for the mothers, also for the babies. I know that the audience is fully aware of that. Now, fasting against medical advice is very common, and that decision should be respected. And patients who insist on fasting, after you present all data to them and the potential risk and so on, to them and to their families on occasions, because elderly patients would their family need to know. Now, these patients, if they still insist on fasting, then you need to fully evaluate them and you need to monitor them, because they will get into trouble if you do not help them how to modify their treatment. Finally, many of our patients, we advise not to fast, and they respect our recommendations, but many of them also, they don't want to fast. These patients also are at increased risk of hypo and hyperglycemia during fasting. So patients who are not fasting, as you know, you could imagine that in this study, they're actually older, they have long duration, so all kinds of increased risk, comorbidities, complications, and so on. And as you can imagine, these patients are at increased risk because they do not eat as they wish to, and they eat after in the 18 hours or so, and they change their life pattern. So they are actually, as reported in this study, at increased risk of hypoglycemia and hyperglycemia. So in conclusions, Dr. Ahmed, the Ramadan Risk Calculator provides a structured approach to assess patient risk, and it is clinically practical. It takes a minute or two, and it is very important that it is approved by the religion advisors and sheikhs, and it is validated now. With that, I thank you very much. Assalamu alaikum and Ramadan Kareem.
Assalamu alaikum. Shukran jazilan. Thank you very much, Dr. Bashar. Really very important subject and really very helpful. Many of us took pictures of your slides, but you have it in the publication so people can look at that. I think, Bashar, I hope you stay with us. The questions will be at the end. I'm sure people might, ask you some questions because it's a very important topic. Let's move on to our third speaker, Dr. Professor Maher Jallo. I think, again, he is a very well-known speaking. And before that, I would like to welcome Dr. Abdulrazak Madani here. He is one of our founders, and he's probably the first endocrinologist maybe in UAE, or the second. Ali Bakr, or you, I don't, Ali Bakr before you, another founding members, and Dr. Abdulrazak, also one of the initial endocrinologists in the country here, and the first UAE national, I would call it, right? And very much welcome for attending this and for the new changes we're doing now. Again, Maher, welcome on board. And again, he's one of the very active, presenter in the Endocrine Club, and would like to encourage you all to start, thinking about joining us and presenting. As we said, we'll leave the questions to all of the speakers at the end. And Professor Maher is well known. I'm not going to speak about you so much, but basically, he is at Tombay University and Hospital, and been very active since he joined here to come to the UAE in really many talks, not only in endocrine, also in other parts related to the field. So today he is going to talk about an interesting case, I would say, not just of polyuria, a stepwise diagnostic journey. Maher, it's all yours.
Good evening, our colleague. Thank you, the Emirate Diabetes and Endocrine Society, Dr. Ahmed, for choosing for the first meeting my case for a presentation. So it is a discussion case, not just a polyuria, a stepwise diagnostic journey. So I think probably I will be much better for me. So this is a case because I involved in it as an endocrinologist because the patient admitted under my colleague. Oh, sorry. Yes, okay. No, it's no problem. That will be fine. Yes. So this patient admitted under the care of my colleague, the nephrologist, Dr. Rajaram, and it is presented in our hospital. So two of our active interns helped me in preparing some of the slides. This is the campus of our university, the Thombe University Hospital and Gulf Medical University. I had to have no disclosure for this presentation. So the learning that will go through the clinical presentation of our case, our patient, then the investigation and workup. We will focus on the etiology and the background pathogenesis and the management plan, and we will take your opinion about further step. So our patient is Abdulaziz, and we told him to use his name. He's accepted. He is 29 years old male, was brought to the emergency department with excessive dizziness that had started during that night. He was unable to walk unaided and reported lower abdominal pain and excessive urination. He mentioned approximately 35 times since that morning. He was subsequently admitted under the care of nephrology at February 28-25 for further evaluation on his persistent polyuria, total duration for nearly 2 months, increasing, but for the last week before admission is markedly increased, with fatigue, terminated with today fatigue and dizziness. The general examination, pale, alert, oriented, but severely dehydrated. Vitals, not significant. Blood pressure, just a part drop of this on standing, 90 to 60 from 110 to 70. Pulse, tachycardia, and respiratory rate is 18. He is unable to sit or stand unaided. Abdomen soft, just diffuse mild tenderness. Cardiovascular, respiratory, no abnormality detected. Neurological, he's alert, intact cranial nerve, and there is no localizing neurological finding, and the musculoskeletal system, normal limb movement. In deep history, there is visual disturbances, blurry vision in the left eye, no history of trauma, no known autoimmune disease, no recent infection or malignancy history, no significant family history of endocrine or other disease, and he's recently undergo nasal procedure, possibly functional endoscopic sinus procedure in his country, and he's married for 2 years with recent history of loss of libido, no children, and no previous detail available because this is first visit in our hospital. So, with this scenario, to summarize that increasing weakness for the past 1 week, severe recent dizziness, polyuria and polydipsia last 2 months, polyuria more than 6 to 8 liters per day, abdominal pain and flank pain, there is no vomiting, and the visual disturbances, blurry vision in the left eye. What next? Yes, he's dehydrated. Yes.
Orthostatic changes? Any orthostatic changes?
Yes, we mentioned 20 systolic, 10 diastolic.
So obviously he's dizzy because of dehydration.
Yes.
Anybody else? Yes, Maria.
So we are dealing here with the young male who is having emergency admission because of severe dizziness and polyuria. So there is element of excessive volume loss, but we need to look into the differential for this polyuria. We, as a clinician, we should think about, is it an osmotic polyuria or some other reasons like diabetes insipidus? So we need to look into the baseline investigations for the patient, starting with the blood profile and imaging as needed.
Okay. So his blood pressure, his blood sugar in the emergency is normal. So the patient admitted. Unfortunately, the patient got very basic insurance. Is not covered only inpatient and also inpatient. For every investigation, we need to write a report to justify. Patient admitted that night, and this is the lab which is done in the same. He's admitted 10:30. So the show 1st March. It is just, the early morning of next day. It is not significant for the usual lab test. The hemoglobin, white BC platelet, just a slight increase in the uric acid. The patient is obese. But any other lab tests you are interested to go through? Other?
Urine analysis.
Yes, urine analysis, general urine analysis.
Specific gravity, maybe
yes,
they're looking at
yes,
specific
yes.
gravity. Yeah.
So further, as my colleague mentioned, the suspicion of diabetes insipidus is there. So further investigation is sent, and urine osmolarity, the serum osmolarity 287, urine osmolarity is 116.2, suggests possibility of diabetes insipidus. Cortisol is low. Free T4 low. Prolactin high. HbA1c 5.4 and the ACTH below 5. So high possibility of diabetes insipidus with other hormonal abnormality of the pituitary gland. Where are we now? What is the next step?
Pituitary brain image.
Okay, so radiology, justify, yes, hardly with the insurance, we got the approval and we perform the, first of all, because he presented with abdominal pain, and the polyuria. For the nephrology side, they take this. So they said retroperitoneal ultrasound, which is unremarkable, no abnormality detected. Ultrasound KUB, kidney, ureter, bladder, unremarkable. because of the previous history of the sinus surgery, X-ray of paranasal sinus, mucosal hypertrophy of turbinate, and the ground glass density in bilateral maxillary sinus suggestive of mucosal thickening. And with this, they advise ENT consultation, who advise to repeat the FIS. Then for the maxilla, CT, which is I suggested by the ENT consultation, there is sinonasal polyposis with a mucosal thickening in the bilateral maxillary and ethmoid sinus with the blocked bilateral osteometial complex, complete opacification of the left frontal sinus and the left frontal sinus assessed by the mucosal recessed by the mucosal thickening and the mucosal hypertrophy involving bilateral nasal turbinate. The CT scan of the chest show mediastinal and hilar lymphadenopathy, multiple micronodules in the perilymphatic distribution in bilateral upper and lower lobe segment with associated ground glass density suggestive of granulomatous disease. Consulted with the ophthalmologist because of the blurred vision and did visual field testing, which is advised to do. It is normal, not significant visual field normal, but advised it is better to go for the MRI brain. And as we plan, till we get the approval from the insurance, so we perform the MRI of the brain. And the brain, MRI brain with contrast, we show suggestive of hypothalamic, optochiasmic mass. They put the possibility of a glioma, which require a neurosurgical consultation and possible biopsy or excision. And this is the MRI. And the details of the report, they mention MRI of the pituitary region, show soft tissue mass involving the pituitary gland, the infundibular stalk, and the hypothalamus. It measures 13 by 12 by 23. It shows intermediate in signal intensity pre-contrast. There is avid post-contrast enhancement with no cystic or hemorrhagic component. The superior component elevates the optic chiasma with bulky, hyper-intense optic chiasma, and there is no evidence of cavernous sinus invasion. So due to the insurance issue, patient preferred to travel back to his home country for further evaluation. He stayed with us in the hospital 3 days, 28, first, second, and we will decide. We start the treatment, we will discuss later, but he mentioned, I will go to my country for further evaluation. So he went back to Jordan. What you expect, what is the further he need to be performed in Jordan on the background of the consultation done in our hospital. We have the CT findings, we have the main, CT maxilla, the ENT consultation, that FIS need to be repeated. So he consult immediately his ENT doctor.
I thought neurosurgeon, not ENT.
Yes.
Yeah.
The patient stayed 2 days with us. At that time, our neurosurgeon is not there. So he went to Jordan, he consulted his neurosurgeon there after the ENT.
Yeah.
Of course, this is the... So his ENT do the FIS and take a biopsy was performed in 15 of March in his country from the right inferior turbinate again, which had polypoid lesion noted during the ENT evaluation. The histopathological examination revealed well-formed tight granulomatous component of epithelioid histiocyte and Langerhans type multinucleated giant cell with minimal lymphoid cuffing, focal non-caseating, non-geographic necrosis. There is no evidence of vasculitis, and they do the special staining, negative special stain for the fungus and acid-fast bacilli Nelson stain, which we should put as differential diagnosis of any granulomatous disease. Any opinion? The patient, and they see the neurosurgeon. He told them for this type, it is difficult to take a tissue biopsy from this lesion. So he stay, I think, 1 week there and come back. Any opinion what we are doing? Dealing, I think one of our colleagues, probably he raised the possibility. Yes, this is one of the differential diagnoses, which is, high in the category for that. Yes, it's what.
Maher,
Yes.
repeat what they said so that the people online can hear their opinion.
Yes.
Sarcoidosis.
Yes, one of our colleague here, face to face, he mentioned it go with sarcoidosis. Yes, I think this is the case in our patient. So these findings are most compatible with sarcoidosis. Differential diagnosis should include the granulomatosis with polyangiitis is also a possibility, but the absence of vasculitis make the granulomatosis with polyangiitis unlikely, and the negative, both special stain and overall morphology favored sarcoidosis rather than other differential diagnosis.
Was ANCA done or EDES done?
We will come. So, any further workup need to be done? Anyone show you my presentation? Yes, of course. When we suspect sarcoidosis and we have the tissue diagnosis, I think we need to confirm. So we sent for the serum ACA level was performed, and it showed high, and the ANCA negative support the diagnosis of sarcoidosis.
Both P and C? ANCA and P ANCA?
I'm not sure for this. Just as I took the data from the patient file, as a consultation for endocrinologist. The patient then stay with the care of the nephrologist, refer him to our pulmonologist for the treatment of sarcoidosis. But I will find that the ANCA is positive, it's negative in this patient. So this finding, as we mentioned, considering the elevated ACE level and the MRI finding, image and the ANCA negative support the diagnosis of sarcoidosis. So I think we don't have any problem now. We reach the diagnosis, and any suggestion where to start, what to do, and of course such case should be managed as multidisciplinary team. The patient managed was initiated with a multidisciplinary team advice to decide the pharmacological regimen to manage, first of all, his systemic sarcoidosis, the central diabetes insipidus, the secondary adrenal insufficiency, and the associated pituitary endocrine dysfunction.
Could be polyglandular neoplasia?
You mean the pituitary lesion?
Polyglandular?
No, sarcoidosis is a tissue diagnosis positive, and it is supported by this. Yes. So corticosteroid started as a management for his sarcoidosis, and of course it will help the adrenal insufficiency. The course is started with 60 milligram and continue towards the tapering schedule. He stay 3 months on 60, then 40, then 20. When he came on September, he is taking 10 milligram, and because with the gradual increase of his HbA1c from 5.4 reaching 6.3, so the decision is made to stop prednisolone and shift him to azathioprine as another medication for sarcoidosis, with probably maintain a small dose for the adrenal insufficiency. Hormonal replacement therapy started with levothyroxine 75 microgram for the central hypothyroidism management, and it is later increased to 100 microgram. Testosterone, from the nephrology side, they start the 250 milligram sustanon injection every 3 weeks, and later we shift him to the long-acting libido every 3 months. Of course, from the first day in the hospital with the diagnosis of diabetes insipidus, I start with desmopressin 120 milligram once, then increase to twice daily, which is bring significant improvement of his symptoms. Now nearly he is asymptomatic and he is still on the treatment. He given, because of the high dose of steroid, the gastrointestinal protection, rapiprazole, and some, simethicone activated charcoal for his, bloating and abdominal symptoms. So the progress, the patient between us, between his country, and we see him as we mentioned in September, the progress with this during the last visit. The patient reported significant improvement, including reduction in the urinary frequency to just 5-6 times per day. The turbinate hypertrophy had regressed, resulting in decreased snoring and improved sleep quality. Follow-up semen analysis showing an improvement in the sperm count and overall general well-being. And because he is now 2 years with marriage, we refer him to the infertility center, the couple, to facilitate, their, getting a child. And he's a free T4 now with target with the current replacement dose of 100 microgram. And because of his high prolactin, also cabergoline is added to his treatment. This is some of the last patient was advised, of course, to continue his current medication and to follow up regularly with ongoing hormone panel assessment. This is the some of the lab which is done in September. It shows that, the ICE start to decrease, after the treatment. Now it is within the normal level. The LH, FSH, it is low, and the testosterone is low. This is before, before his dose of Nebido. And for that reason, the patient and the couple referred to infertility center. So we say that probably now sarcoidosis nearly under control, so probably there is any regression in the pituitary mass. So the MRI is repeated, and unfortunately there is no significant interval change noted in the pituitary mass. It is still measured before 12, now 10 to 7 millimeter in axial, and the cellular floor is intact. There is no paracellular extension, no significant interval change noted in the hypothalamic pituitary stalk mass. Is still measured 15, 11, 12 in axial dimension, and the lesion is still inseparable from the optic chiasma. Subtle interval increase in the size of the left medial temporal lobe, currently measuring 975 dimension compared to 774. Not significant change. So the opinion, largely stable appearance of the pituitary, hypothalamic pituitary stalk and left medial temporal lobe lesion, and there is no acute intracranial abnormality. So the key consideration, I think, from this rare case, that early diagnosis and the treatment is important. Prompt recognition of pituitary sarcoidosis can prevent permanent endocrine deficit. Multidisciplinary approach management require coordination between endocrinologists, neurosurgeon, radiologist, ophthalmologist, and the ENT specialist and pulmonologist. Long-term monitoring, ongoing evaluation of the hormone level, and imaging is essential to monitor disease progression and the treatment response. So to conclude that sarcoidosis is a multi-system granulomatous disorder with rare central nervous system involvement. The case emphasized the diagnosis challenge of pituitary sarcoidosis due to its rarity and non-specific clinical presentation, making this, up to my knowledge, it is the first reported cases in the Gulf. In patients with unexplained endocrine dysfunction and radiographic evidence of granulomatous disease, sarcoidosis should be high on the differential. And early recognition and the treatment with corticosteroid can lead to significant clinical improvement. This is the usual 90% of the sarcoidosis in the lung. In the system, the liver 20%, eye 20%, skin 15%, heart 5%, kidney 5%, and all the central nervous system involvement 5%, in the pituitary 1 to 2%. So I think it make it, 2 to 3 slides about is a rare neuroendocrine manifestation less than 5, where granulomatous inflammation affect the hypothalamus and pituitary gland, commonly in adults age 20 to 40, more in the female rather than male. Our patient is male. The infiltrative process often involves Apache destruction of the hypothalamic pituitary tract, resulting in various combination of anterior and posterior pituitary hormone dysfunction and sometimes isolated dysfunction, and sometimes reported cases of only pituitary involvement without systemic sarcoidosis. It typically causes hypothalamic pituitary dysfunction, including diabetes insipidus and hormone deficiency panhypopituitarism. Of course, the contrast-enhanced MRI, often showing the cellular paracellular mass, endocrine testing are key of the diagnosis. Treatment primarily involve corticosteroid with immunosuppressive like methotrexate as second-line agent. And what does the corticosteroid do? It is lower the CD4, CD8 lymphocyte ratio, decrease interleukin-2 production, and inhibit the collagen synthesis, all of which are abnormal at the site of active disease within the brain. The clinical presentation is not differ like our patients. Symptoms often include polyuria, polydipsia. Some patients present with headache. Our patients don't complain. Visual impairment, fatigue, and weight loss. The endocrine dysfunction commonly causes diabetes insipidus in 40% of the cases, and variable anterior pituitary insufficiency, ACT age, the TSH growth hormone or gonadotrophin deficiency. By the way, the patient performed in his country the IGF-1, and it is in the lower normal level, so there is no abnormality with this. The imaging MRI is the diagnosis. Usually the diagnosis and often mimic pituitary adenoma, which can lead to unnecessary surgery. And you see the report of the first MRI, they put the glioma as a possibility. Diagnosis is confirmed by the histological evidence of non-caseating granuloma or by evaluating the systemic symptoms, and the management, as we mentioned, corticosteroid and hormonal replacement. First line is the corticosteroid. Second line could be any of the immunosuppressive drug, and the outcome, the prognosis depends on the extent of the central nervous system involvement, so early detection can prevent severe pituitary dysfunction. And from the history that 3 decades ago, the mean survival in hypothalamic pituitary sarcoidosis in a review of 19 cases was only 45 months. And now there is reported cases living with the problem more than 20 years. So this is, some of the very few reported cases. The systemic sarcoidosis with pituitary adenoma. This is showing the effectiveness of 18F-fluoro deoxyglucose positron emission. Probably this is a new radiology technology, scan in the diagnosis and monitoring of the systemic sarcoidosis with the probable pituitary involvement. So probably it is a whole body scan. And the other paper, hypothalamic pituitary sarcoidosis, this is probably the first published cases of 1961. The search for sarcoidosis in case presenting as idiopathic hypothyroidism, hypopituitarism, and or diabetes insipidus, elevated cerebrospinal fluid protein without other prominent cerebral symptoms occurred in 3 patients. This is reported 4 cases, all of whom had diabetes insipidus, may be of considerable diagnostic value. We don't perform the CSF analysis in these patients. A progression of diabetes insipidus occurred in 1 patient treated with a steroid, so he's clear from diabetes insipidus. This is 2 reported cases on 2 patients still alive after diagnosis 20 years ago. And the granulomatous infiltrate of the pituitary gland report a case of pituitary sarcoid without the multi-organ involvement typically observed in systemic sarcoidosis. So sometimes probably it is only the CNS involvement. And for that reason, because the difficulty in diagnosing, in categorizing the patient, a group of interested, from Europe, the definition and consensus diagnostic criteria for neurosarcoidosis from the neurosarcoidosis consortium consensus group. Now there is consensus group for every diagnosis. And they decide that the pathologic confirmation of granulomatous disease was used to sub-clarify the neurosarcoidosis. Either definite confirmation in a neurological tissue, biopsy from the CNS. Probable confirmation in extra neurological tissue. So Abdulaziz may be in the probable. And possible, there is no histopathological confirmation of the disease, but probably the clinical presentation, the ACE, or the other diagnostic done. And according to this, a meta-analysis of nearly 80 cases, according to this, consensus, clinical characterization and outcome of 85 patients with a sarcoidosis. This is a cohort of European. In this Southern Europe cohort, 5% fulfilled the criteria of a neurosarcoidosis recently proposed by Stern et al. So the data is only 5%. And among the 2 main subsets of a neurological involvement, the CNS involvement prevails significantly over the paranasal sinus involvement. And both conditions don't overlap in any patient of the 85. In Abdulaziz, we have probably, if it is the pituitary is also sarcoidosis, this is an overlap with this. The systemic phenotype associated to each involvement is clearly differentiated, and the lower thoracic and the greater ocular and the glandular expression in patient with CNS involvement is clear, while the greater hepatosplenic expression in those with the paranasal sinus. So probably this differentiated system expression can be helpful not only in the early identification of the neurological involvement, but also in the systemic evaluation of patient diagnosed with a neurosarcoidosis. I think this is the last slide, and we don't need to speak about the sarcoidosis. This is the reference, and thank you very much.
Thank you, Maher. Excellent, very interesting case. I think we'll ask our colleagues to come here and to open for questions. Dr. Abdul-Razak.
Well, thank you, Dr. Maher. A very beautiful presentation, a very, very rare case. I personally haven't seen any case of that, but, it's a very beautiful one. Yeah. But, I'm wondering, a young man who's married for 2 years, has lots of libido, and, doesn't consult a doctor. He waited till it went into the diabetes insipidus. It is a bit, strange, He had hypothyroid, he had adrenal, but I think lots of libido at this young age, 2 years after marriage. It should, should send him to a doctor.
Yes, I know, but unfortunately, some of our patients are so poor for the insurance cover. This is insurance not covered in any outpatient, only inpatient admission. And if he don't present with these severe symptoms, we will not get the approval of insurance to admit him, and the privilege of perform all this. And when he's stuck with performing further investigation, he went to his country. And now I think for the infertility, he went to his country because I don't think he's able to afford any of the investigation of infertility management with his, current situation.
I think,
Aftab, yeah.
yeah, I was going to say, I think there is a bit more to it. I think men are very reluctant to come forward with this, okay, in front of their wives, but doctors. I had a recent case, fully insured, I could have done anything, loss of libido for at least 3-4 years, and I raised it with him. I had to ask him. I said, you should have, because his prolactin was high. He said, Doc, if you hadn't asked me, I wouldn't have told you. I wouldn't have told you. I wouldn't have discussed it with you. It's very personal and embarrassing for me, but I don't want to discuss it with anybody. And once I opened the discussion, he then opened up and we had a very long discussion. But I think it's a man thing. I think we have to keep that in mind. We do not want to discuss these things, even with doctors, unfortunately. His marriage was suffering. His wife was very angry with him. He would not talk to a doctor. He would not disclose it.
Yeah, that's true. And if he is a bit elder, over 50 or 40 or something.
This was a young man
and
I'm
has
talking
children.
about.
But a young man recently married, it's, a bit. And as Dr. Maher said, he could have gone back to home, if it will be costly for him to do it here. He could have gone back home, and how, his wife didn't push him also to go for that. The other thing, Dr. Maher, I want to ask the testosterone here for this man.
Yes.
Don't you think if you had given him, gonadotropin, that would have, reserved his testicle better, because testosterone may suppress his testicle even more, and he's looking for fertility.
Because we don't have because we don't have an infertility care in our hospital, really I don't want to be alone involved in management. Such patient is an infertility problem, so they need to manage as a couple. So it is better with this condition, I refer him to an infertility center.
If I may, if nobody asking, you'll have, just let me ask a question, then I'll come to you. From what you mentioned and from the papers, the pituitary did not change, the lesion in the pituitary.
Yes.
So could it be something separate?
Could be, because we don't have tissue diagnosis, but sometimes they mention 6 or 8 months of a treatment for sarcoidosis may have done significant impact on
Pituitary, because the other side was responded well, right, on the sinuses.
Yes.
Yeah.
Ahmed, can I make a comment, please? So Hassoun.
Yes, go ahead, Bashar. Thank you for joining us. Go ahead.
Yeah. I had a similar case. However, the diagnosis was TB actually. TB and diabetes insipidus, and all resolved after treatment, confirmed by biopsy actually. Almost similar case, but it was a TB.
Yeah. That's, sometimes we see these cases, but again, I've got also rare cases. Thank you, Bashar, for commenting on this case. Any question about his case presentation? Maher? No? Not really. Okay. Farial, go ahead.
Thank you, Dr. Maher, for the beautiful presentation. I have a question regarding the initiation of cabergoline in this patient. As we know that it's an infiltrating disease secondary to sarcoidosis, and prolactin could be high because of stalk compression effect. So were we suspecting that there is an hypersecretion of prolactin as well? Because the level is around 700 to 800.
So we postponed initially taking the consideration the hypothyroidism. Mm-hmm. When we escalate the dose of his thyroxine, and now the T4 is within normal, and the patient got libido, so probably it is part of, to manage his low testosterone and high prolactin. And I think in this scenario, it is justified. He just start in I think October, that we have appointment to be seen in December. He's still not come. If it is a drop, I think, it is justified that, this will be.
Or if we are thinking that as the size of the pituitary lesion has not reduced, so we have two diagnoses at the same time. So
Yes,
let's
but still no neurosurgeon with this scenario want to go for surgery or for biopsy of the lesion. So I think before thinking of two diagnoses, which is possible, but at least with the new criteria, a probable is still there.
yeah, definitely.
Great.
Thank you.
We have, thank you. We have a question from the online group here. I think Dr. Aftab is about your presentation. Regarding placing all patients with diabetes on SGLT2 GLP-1 agonist, this cannot be generalized to all patients. Still, their CVD protection has been shown in patients with high risk. Not all patients with diabetes are high risk. I mean, he's questioning what you said there.
I think we're not talking global data. We're talking UAE and we're talking Middle East. And I think repeated studies have actually confirmed that, like I said, PACMEA score 2, that essentially all our patients are high cardiovascular risk. And I think we have to be very, very clear on that, okay? Now, if you actually find one patient who's purely diabetic, who's got no lipid problem, no hypertension, does not smoke, is not overweight, is obese, good luck with that, because in 8 years, I haven't found one, okay? So if you obviously have one of those patients, yes, you can consider them low or moderate risk, but with more studies coming out, I can assure you, every single patient globally will be found to be, because we know now that diabetes is not a glucocentric issue. We have got oxidative stress, we've got endothelial dysfunction, we've got inflammation, fibrosis. So please reconsider this thought that not all patients, and I am actually saying it's a general statement, and that's why I put it for proposal. We need to consider it uncontrolled.
May I add something related to this? You mentioned very nicely that all your patients, all the patients should be on SGLT2 from the beginning, type 2 diabetes. And assuming that we know, and what you said also, that this is not happening. So if somebody comes to you with a microalbuminuria, right, and he is not on SGLT2, how would you approach both of them? SGLT2 first? Let me know how you do it.
Yeah, I mean, okay. So the thing is, at this very minute, the suggestion is you can start both of them together. I, however, because this is not, 3 months is not going to cause the damage. Stepwise is not an issue as long as the inertia doesn't go beyond the 3 to 6 months. I don't have a problem starting SGLT2 first. I give them 3 months, even 6 months, repeat the ACR, and if it is high, they go on finerenone. The world evidence is now going, they're saying put them on together because we are trying to stop the inflammation and fibrosis that we know is going on and in the future will. So that's going to be a gray area, but stepwise is fine. 3 to 6 months, no more. Inertia is about delaying.
More challenging to this again, if they are obese, would you add the GLP-1 rather than, because both of them have benefit also?
I'm without a doubt. See, I've got the privilege at the minute that majority of the patients are thicker patients.
Yes.
So I don't, I'm fortunate that way. So I sit down with my patient. It doesn't take more than a few minutes. I tell them about the cardioprotective. I show them the evidence on the combination, and they're very happy to go on it. Even the ones who are reluctant on injectables, they take it for cardio-renal protection. Every single one of my patients actually has understood the concept of cardio-renal protection. Right. So I tell them it's not for your weight. I'm not giving it for your HbA1c. It is to prevent heart attacks and jalta. And they listen.
Great, thank you. Yes, please.
Yes, thank you for sharing your center data for the patient using the cardioprotective medications, and you publish in 2024. We publish our data in 22, and this is the study which is conducted in 21, 1 year after change of the guidelines, adherence of physician for the cardioprotective medication for high-risk patient. And we had 65% of our patient on either the SGLT2 or GLP-1 therapy. Taking in consideration, we don't have the privilege of Imperial. We accept all the insurance, even the basic. Some patients self-pay. And I think, with this probably one of the highest adherence among all the published data in the region. So I think, yes, if you are interested to take care of your patient and you have the chance and discuss with the patient, you can. But unfortunately, the insurance become more and more tight. Now we have 20 or 30% copay. We have certain, sum of money for the pharmacy, 5,000, 4,000 per year, and should be go for the priority. If we put all our patients on GLP-1 and SGLT2, he will finish his, allowance in 2 months and remain, So I think we should be, taking the priority. The guidelines tell us patient with high risk atherosclerotic cardiovascular disease. I don't think we have till now a strong evidence-based data for patient newly diagnosed for primary prevention without heart failure, CKD, established atherosclerotic cardiovascular disease.
Thanks, Maya. Actually, there is data. They've done a meta-analysis. They took out all the high cardiovascular risk patients, just the high cardiovascular risk with no established disease, and they found the same thing. It reduces mortality and MACE. So that data is there. I take your point about insurance. The proposal I had wasn't, I know there's a limitation. The proposal I'm putting forward is, as clinicians, we could at least start documenting the fact that this is uncontrolled because they're not cardiorenal protected. There's no harm in that. There's no money spent on that. It is a change of attitude in physicians approaching the disease now, that it's not glucocentric, because at the minute the documentation is well controlled because HbA1c is within target. So my proposal is not that you have to or you can. My proposal is, as physicians, we should start documenting this is uncontrolled because the primary aim, which is cardiovascular protection, is not being met on sulfonylurea and DPP-4. That's what I'm proposing.
Right. And I think that to add to this is, I think all of us here, we probably should look into our institution and our hospitals, our clinics, if, for example, SGLT2 is needed and it's not done. So that's some good encouragement to go ahead with that. Doctora, just introduce yourself. I don't know your name.
My name is Dr. Mehek, and I'm an internal medicine specialist and endocrinologist from Pakistan. And currently, I'm practicing telemedicine on one of Pakistan's largest platforms. So we see patients from all over the world in our telemedicine clinic. Thank you for your presentation, Dr. Aftab. I have 2 questions regarding both of your presentations on using SGL2 for cardiovascular risk and finerenone. My first question is that when we're working in low-income settings, can we start oral GLP agonists if we're not able to start injectable GLP agonists for patients with high cardiovascular risk?
Absolutely. Oral semaglutide has shown a similar benefit now, and I think more studies will come out. They won't be far behind. Absolutely. Oral is as good in my books as, injectable. It's better than nothing in cardiovascular protection. Absolutely.
Right. And Dr. Aftab, I had a patient. She was a known case of type 2 diabetes since the last 20 years. She was an obese patient, 68 years old female with CKD stage 3. She had persistent microalbuminuria since many years, despite being on SGL2 inhibitors. She was on dapagliflozin 10 milligrams. And she was also on ARBs. She was on valsartan 160 milligrams. That's a tablet we have available in Pakistan. So eventually the patient developed hyperkalemia. Her potassium rose to 5.9. And the nephrologist, they stopped her ACE and they switched her to hydralazine for blood pressure control. But again, she had persistent microalbuminuria. So in this patient, when they corrected her metabolic acidosis, the potassium levels improved after that. My suggestion in that patient was to the nephrologist to start finerenone, but then the nephrologist was worried about hyperkalemia. And I just heard from your presentation that when a patient is on SGL2, we shouldn't worry so much about hyperkalemia. So should we have started finerenone in this patient?
Absolutely. It actually improves that the combination has less risk of, and again, I think the hyperkalemia, I still believe it's overblown. I don't know why or how it happened, but it is overblown in my books because it is a clinical hyperkalemia. And the guidance is there. You monitor it, you reduce the dose, you stop it. It's not fatal. The hospitalization is minimal. The fear is beyond me. And fear in endocrinologists is just I don't understand it. So of course we should start it. Okay. In Pakistan, I think the other thing is I've just heard that Ozempic and Mounjaro are being produced at rupees 1,000 and 4,000. So we should really be in that country. We should be able to provide that to huge population.
Doctor, I'll add to this. We do have local companies that are producing tirzepatide and
I know,
semaglutide
I have
at
just
very
heard.
nominal cost.
I know.
But I was discussing with one of the consultants in the Dubai hospital about this, and they told me that we are not sure about the safety data of these newly manufactured medications in Pakistan.
I think
So should we be, when I discuss with my patients, so this is one concern that I expressed to them. So should I be more liberal in prescribing these medications for them?
we will have to. I think the problem is if you look at the generics here, unfortunately, even in this, where the insurances are good, the generics are being used. We haven't seen their safety data. We haven't seen but they are being used and they're being licensed and so on and so forth. So the companies I know in Pakistan are very reputable who have done it.
Yeah.
So I think it's worth a try.
But I think Aftab, maybe they are getting the material from the original company, like in Egypt, for example. I know they are, for example, tirzepatide is done in a different way, but again with agreement with Eli Lilly. So maybe the same thing. I wouldn't think they will do another thing, another new molecule by themselves.
That's
it's probably
when-
the same material. They just have agreement with the company to put it in a lower price in a different way. For example, it's a vial, to my knowledge, in also in Egypt. Yeah.
Thank you so much, Dr. Aftab. Thank you so much.
Check the potassium first before start. This is very important. And don't dispense the 10 milligram just for 1 month. After 1 month, check the potassium. If it is fine, you can upgrade to 20 milligram. If it is normal, you can upgrade to 20 milligram. If it is high, you can stop temporarily and probably you can start after that. Of course, with the advice the patient to avoid the food with rich potassium with this. I think it is because sometimes the patient, he wants a 3-month medication. No, I think with this, you should dispense just 1 month, evaluate after 1 month, and then you can go.
Bashar.
Yeah. What do you think the mechanism of hyperphosphatemia in the case you presented? The serum phosphate was above the upper limit of normal range. And have you considered doing 24-hour urine for calcium?
Phosphate high?
Yeah, I think the serum phosphorus was
I don't.
4.9 milligram per deciliter.
High normal or high?
It's above the upper
Above
limit.
the.
4.5 upper limit and then 4.9.
And there was another question about the sodium being normal in this case, also, Maher, from the online people. And it probably is due to the steroids is also deficiency. That might be having some effect. And one important point for the people, need to know is that it's good to correct the steroids before you correct the thyroid because you can put them into trouble. So that was a good move you did. Yeah.
I think his patient is because of dehydration. He's received, good amount of normal saline in the emergency before get the approval to be admitted inpatient. And this lab test was conducted when the patient inpatient because his insurance is only cover the inpatient. So probably will correct his sodium. Really, I don't have any explanation for this 4.9 of phosphorus.
Okay. Question there? Yeah, go ahead. Introduce yourself, please. Your name?
I'm Dr. Hiya Boro. I'm an endocrinologist at NMC Healthcare in Sharjah.
Very good.
My question for Dr. Aftab. Sir, I met you before once in a meeting at Sharjah, if you remember. And my question for you is that till what GFR you can use Finrenon? And are there any specific age, is there any age cutoff where you would be cautious while using this drug, or any specific like things like advanced cardiac disease or specific age group?
The EGFR, if I'm not mistaken, is more than 25, so you're allowed to use it, and there are no limitations to it. Age is definitely not a limit, a restriction. As a matter of fact, I think in medicine, ageism has been out for a while now. WHO has declared 80 years as elderly, not even old. So age is out. I think it depends on the comorbidity of the patient, frailty of the people. It's actually beneficial in people who have got heart failure. The Fine Hearts actually took them and they So no, apart from the hyperkalemia, that's a limitation in our minds. I don't see any other restriction. Unless Maher, you've got something.
Great.
I think, the microalbuminuria sometimes really it is a challenging, if you go for the report of your patient, sometimes he got positive microalbuminuria, next visit it was normal. So should be documented in more than one visit to say that it is microalbuminuria to justify start a new treatment. We finalized and published a study from WHO grant, and we are studying microalbuminuria among the relative of patient with diabetes and hypertension, healthy, no any risk factor, and the data 9.5 of those patients positive microalbuminuria documented in more than one time, with excluding with the possible cause. And now with an ethical consideration, what to do with those. We advise lifestyle, yes, so not to progress for diabetes or limited the salt, not to go. But do we need those patients because of just screening for microalbuminuria and detected to put the medication there?
I think, Maya, we're talking diabetes. Finerenone is type 2 diabetes, not for general population. But if you have got a general population of microalbuminuria with no other cause, I think that's where the referral to nephrology for a primary disease is important. I don't think I will leave them alone as such. But no, the finerenone, we're talking specifically type 2. We're not talking about general population.
Any other medicine? Any other medicine to help them or just to follow up?
No, I think a referral to nephrology, I would ask them to look for a primary cause first. They sometimes have to do a biopsy to look for or further investigation. So yeah.
And sir, if
I
a
agree with that.
pre-diabetes patient has microalbuminuria, because pre-diabetes itself is also a risk factor for end organ
There is
damage.
all other parameters are normal.
Hyperfiltration syndrome. This is maybe one of the reasons for the microalbuminuria, and also this is only one test, or they repeatedly they have
twice.
twice.
Documented it twice.
And
with all other
all-
parameters of renal parameters normal, HbA1c normal, fasting normal, all other.
even though this was started with the hyperfiltration, one of the stage of first step in the
yes, but
development to hyper.
9.5%, among 200 patients, we have 18.
So I think to treat only patients who have diabetes
Of
or
course.
other causes, hypertension,
Of
but
course.
patients with completely normal,
Those
there is no
high-risk
need for
patients
that.
with cardiovascular disease and need to be managed and decrease or revert microalbuminuria as much as possible. Yes.
But they need follow-up, I think, those
Yes.
From primary care point of view, we see a lot of mild people, mild diabetes, like sometimes diet controlled, metformin controlled. Do we have to push all these medications on these patients who are very mild?
You need, I think those patients need proper.
If there is no other parameters, no albuminuria or anything else, just mild.
Take that.
Take this one, yeah.
Okay. I think the first thing is I would refrain from using the word mild. Okay. There's no such thing as mild diabetes or mild hypertension or mild hyperlipidemia. They have either got controlled or uncontrolled. Mild leads us to this clinical inertia that's, there was a survey done actually on physicians, and HbA1cs of, let's say, 6.6 and the target was 6.5, and LDLs were 1.9 and target is, and they asked, why don't you do anything? And they said, close enough is good enough, which is the mild. There is no such thing as mild. Cutoffs have been put on because there is no such thing as mild. Let's say the blood pressure 130/80. The reason 80% of patients are undiagnosed and untreated is because 131/81 is considered mild. There is no such thing as mild. That's the first thing we need to remove. And yes, it's not the word pushing is not you're pushing into it. You're actually saving lives. The evidence is not 10 patients or 20. These are hundreds of thousands of patients have been looked at, followed up for a huge amount of time. I showed you the Danish data, 20 years data. You are saving lives. It's not about pushing. I think that is coming from the fact that 30 years we've focused on HbA1c. We're thinking, what's the fuss now? The fuss is what we were doing wasn't necessarily correct. Things have changed. I've shown you the guideline. It's a dramatic shift. It's a paradigm shift.
So we shouldn't check hemoglobin A1c anymore?
No, hold on. HbA1c is always going to be the gold standard. It's the initial management. Initial management has to change. SGLT2 has to be added irrespective of the HbA1c. And then once you have done that, HbA1c is above your target, whatever target you're following, then you bring it down by adding other medication.
So without heart disease or without kidney disease, you have to do SGLT2?
That's what your high cardiovascular risk means. High cardiovascular risk patients in diabetes are dying despite of having an HbA1c within target. That's the evidence.
And we have to convince the patient to take these medications, even though they come back to us and say, well, I have no this, no that, no this, no that. Only my sugar is a bit high. I will quit eating sweets and quit the fatty stuff and do exercise and normalize everything. I have seen these patients, by the way.
I know.
And we have seen patients for 20 years, their diabetes stays, you don't like the word mild, but for patients, they consider it as barely any.
I totally agree.
So how can we justify giving them 2 medications, maybe 3, for 20, 30 years?
I totally agree with you. And I see these patients every day, okay? And it takes me 5 minutes to explain to them why I'm doing it. And I can promise you, not a single patient has. I've got more than 4,000 patients under my care, and not a single patient has defied it. The word is cardiorenal protection. They understand that. They understand death. So it's not a difficult communication to have. The conviction has to come from us. Unfortunately, we are the ones that need to be convinced, not the patients. We as physicians, you know, the clinical inertia, you have seen the data for clinical inertia. Everybody's talking about inertia. It's with the physicians.
I have a problem with patient inertia, not doctor inertia. The problem is with the patients.
My experience is slightly different.
You know that. But you have to understand also there's a difference between a primary care doctor talking to a patient versus a nephrologist, cardiologist, endocrinologist.
Correct.
By the time they go to you, they are already convinced.
Correct. I think the proposal that's what the proposal I'm putting is this. These limitations are there, you're right. Patients, not everybody is going to be convinced. The least we can do is document it. Uncontrolled diabetes, patient refuse to go on any further medication, or insurance limitations, or funding is not there, whatever. The documentation can still be there. Our documentation can change. That's my proposal. I can't overcome, nobody can overcome the limitations.
I think it's becoming clear now. I think the issue with the primary probably is also the time. I think that's the thing. If they don't have time to discuss, like we have maybe some more time than them, then we have the luxury of convincing them. And I think you're right. Education of the patient is very important to tell them about the pros and cons. But time sometimes limited, even to us sometimes, and I'm sure to the primary care is probably more. With that, I would like to have only one last question. If there's no question. Last short and and short answer, please.
Dr. Aftab, I have a question which is an extension of the question the doctor asked. Like, for example, I have a 70-year-old patient. She has type 2 diabetes mellitus and she's well controlled on 500 milligrams metformin twice daily, and her recent HbA1c was 5.5. Should I switch her to an SGL2? Should I remove the metformin and switch her to SGL2, or should I add the SGL2?
Again, I think you're bringing the age. Let's say it was a 40-year-old. I don't think there will be, it's the age bit. Is she a fit 70-year-old?
No.
Has she got comorbidities that you think the mortality is 5 years away? Then there is no point, because the mortality data is 5 to 10 years. Yeah. So that's what you have to assess in a 70-year-old, not the age. Do you see them living to that? They need to be healthy. You don't want them to spend 5 years with a stroke. That's the answer. It's the practicality of it.
And
it's
if
the
you have a newly diagnosed type 2 diabetes with an HbA1c of, for example, 6.7, should we consider starting them only on SGL2 and not starting them on metformin at all?
The guidelines are, evidence is clear, irrespective of HbA1c. I can't say it enough times. It doesn't matter what the HbA1c is. 6.7 is, in my books, uncontrolled. We are in the days of clinical remission now. The drugs that we have got, such as the GLP-1s and the glitazones, which is practically first line because 40% are fatty liver, we are in the age of clinical remission. We should be aiming for 5.6 without fear, because these drugs don't cause you hypo and they don't increase mortality. So I think that's the mentality shift that we need to think of.
So
That's my
we
view.
don't start them on metformin at all, because I have patients who are newly diagnosed type 2 diabetes. They've had
Dual
a very
therapy.
erratic lifestyle.
Dual therapy.
Dual therapy
I
is
go
better.
for, yeah, once
Dual
daily.
is better.
More question to Dr. Aftab
so
later
much.
on with the dinner time. Yeah, yeah.
Thank you so
Right.
much.
I think with that, I would like to close here, and I would like to thank you all for being here with us face to face. I'd like to thank also the virtual online people who are also with us, and they were having some questions here. I would like also to, again, thank Dr. Fathiya and the Society of Emerging Diabetes Endocrine for having this initiative, working with us as Endo Club, and I think this will add a lot of power to this club and to be more consistent. And not to forget, our speakers, excellent job, Aftab, Maher, and Dr. Effendi. Dr. Effendi just have to leave us, and he's not online, but he apologized for not being with us. And with that, I would like to remind you that this is a CME accredited, and it will be sent to you in 2 weeks' time. And with that, we're going to look more for monthly activities going on. We will let you know. Thank you very much, and looking forward for future meetings. Thank you.